Okay, just is it okay to start now?
Oh, okay. Yeah, I think the time it's already 13 p.m. Okay, let me start this event. Good afternoon, everyone. Welcome to the online lecture series, which is the collaborative partnership event between Indonesian Medical Education and Research Institute IMERI and ASEAN Pacific Society of Hospital General Medicine, APSARA, and this event facilitated by Allm in Japan. Okay, actually we have 7 online lecture series, and today is the second one, right? Dissemination of General Medicine Technology in Indonesia with topic clinical reasoning. Okay, today we have 2 distinguished speakers, which is Dr. Sayaka Aoyama. Welcome, Dr. Aoyama. Yeah, Dr. Aoyama, it's from Department of General Medicine, Mito Kyodo General Hospital, Japan. She is graduated from the University of Toyama, Japan, and currently she is at 3rd-year residence in the Mito Kyodo General Hospital, and she managing online clinical reasoning lecture for medical students. Today, Dr. Sayaka Aoyama will present case of 67-year-old man with syncope. Okay, Dr. Sayaka Aoyama, the time and screen are yours, please.
Yes. Oh. So can you see my slide?
Yes.
Okay. Okay, nice to meet you. I'm Sayaka Aoyama from Japan. I'm happy to study together today. And I want to share the 3 tips of diagnosing in 30 minutes today. So now I'm in my hospital. Please visit to Japan after the coronavirus pandemic. I want to see you soon. So have you ever thought how we diagnose? We take 3 systems in daily diagnosis. The first one, the system 1, it's intuition. When you see the patient and diagnose at once, you use system 1. The more experienced you are, the quicker you can diagnose. System 2, search the diagnosis. Now search the disease. Use Google or read books. Gives a list of differential diagnosis. These 2 processes are called dual process theory. If you are young and want to be a good doctor, use the dual process theory for all the patients. System 3, it is called lateral approach. It is another method of diagnosis. Please ask the patients, what do you think of your disease? If the patient has the same experience, they will tell you what is the diagnosis. For example, when you ask the patient about the chest pain, your patient might tell it is myocarditis because he had the same symptoms last year. So please use these systems from 1 to 3. You will diagnose quickly. However, sometimes we fail to diagnose at once. Why do we feel difficult to diagnose? Even if it is rare disease, you can diagnose easily if you know. Look at the difficult one. Even if it is common, the atypical clinical course makes difficult to diagnose. For example, the myocarditis without chest pain sometimes come because of the dizziness. If you know the tip, you will take ECG. However, if you do not know, you will miss the myocarditis. So the very difficult one is rare and with a typical clinical cause. The study says what is the most important thing. It is the medical history. The paper says the 80% of contributed factor was the medical history. The famous Professor William Osler said, listen to your patient. They are telling your diagnosis. That leads us to the tip one. The medical history is the best contribution to diagnose precisely. So please listen to patient. From now, I want to share the case. The patient is 60-year-old Japanese man. He said he has difficulty in breathing, back pain, and his family tells some fainting episodes. So from now on, fill things the differential diagnosis with a slide. To see the history of present illness. A 60-year-old man comes to the emergency for the evaluation difficulty in breathing and back pain. 1 day ago, he felt the difficulty of breathing and back pain. He has also been extremely fatigued. His family reported his fainting with incontinence after he woke up this morning. He sometimes fainted after standing up. So tip 2 is rank the multiple complaints in order of importance. Where is the most important complaint? The patient said the difficulty in breathing, back pain, feel extremely fatigued. His son said he has sometimes fainting episode with incontinence. So what is the most important? As you know, fainting with incontinence. So now we focus on fainting. What should we think? So we should think this. To be altered mental status or syncope? That is the question. So I want to tell the reason why I put this sentence in tip 3. Because the differential diagnoses are different between these two diseases. If you think it is altered mental status, you should think IO tips. There are so many differential diagnoses. If you think the episode is syncope, you have to remind 3 things. Is it neurally mediated syncope, cardiogenic syncope, or orthostatic hypotension. The differential diagnoses are totally different. So let's review the definition of syncope. The syncope is characterized by a rapid onset, a short duration, and spontaneous complete recovery. So let's review his medical history again. We asked the episodes in more details. The onset. It occurred when he stood up. He had several times last month. The duration time was 20 seconds. It was the first time to have the incontinence. And the family reported systolic blood pressure was 60. It is very low. So from this episode, we can think his symptom was syncope at all. So we should think these three things. So what will we do when the syncope was suspected? Please think of it. So we think this like this. So cardiovascular disease, orthostatic hypertension, neurally-mediated syncope, the bleeding. So we did such the laboratory data, ECG, echo, and electroexam, and X-ray. So before diagnosing, don't forget to ask past medical history and so on. Please make it the routine. So I show the past medical history. He has type 2 diabetes mellitus. And he has a craniopharyngioma. It was post-operative. Diabetes insipidus. The endocrinologist said it is mild and very controlled. We go to the social history and family history. He has no allergies. He never smoked. He sometimes drinks alcohol, but he does not drink alcohol too much. His family history was non-contributory. He works as a dentist. Medication. He takes the glycine phosphate hydrate and metformin for type 2 diabetes mellitus. He also had desmopressin for craniopharyngioma and diabetes insipidus. So let's move to the physical examination. The vital sign, blood pressure was 147, heart rate was 76, saturation was 99% linear, the temperature was normal, the general appearance was good, a medium height and weight Japanese man, he is alert, and he speaks preferentially. here is his results. From head to toe, it was unremarkable at all. No conjunctival pallor, no irregular sound in chest. Abdomen was flat and soft. The limbs was no edema, not cold. The neurological exam was unremarkable. So we suspected, we are afraid of having syncope. So we did lecture examination. So it was class 2. So please think, what is your diagnosis? It's most likely. Of course, we take the laboratory data, but it takes time to know. So the waiting time, we did ultrasounds. The ultrasound showed ascites around kidney, spleen, and Morrison fossa. The left lobe of liver was atrophied. Gallbladder, the wall is a little bit thick, and gallstone was also found. A splenomegaly was also found. The heart is unremarkable and it was normal. ECG, it was normal. Heart rate was 72. Sinus rhythm regular. So here is chest X-ray. What do you think? Do you think is it abnormal or not? Please check it. So do you think mediastinal enlargement was seen? And CP and the left of CP angle is down a little bit. So here is laboratory data. The AST is elevated. The total bilirubin was also elevated, but direct bilirubin was not elevated. White blood cell is also elevated a little bit, but neutrophil was normal. The hemoglobin was low, 10.1 grams per deciliter. And CRP was also elevated. So now we are suspecting on breathing. So we did abdominal contrast enhanced CT scan. Please watch and think what is abnormal. So here is the answer. Esophageal valve, coagulation, and ascites are seen. So now what is your diagnosis? You already know. So the final diagnosis is rupture of esophageal varices. So we did upper gastrointestinal endoscopy. Here is the pictures. It is very broadly, isn't it? So we are wondering why he has explosive barracks, because he didn't drink alcohol too much, and he is a dentist and very educated. So we search for the reason. So here is a pathophysiology. He has a craniopharyngioma, and it is related, honestly. The pathological history is very important to understand the pathology. The craniopharyngioma is a list of the non-alcoholic fatty liver disease. Patients with hypopituitarism and resultant growth hormone deficiency develop the obesity and insulin resistance. The reason of his diabetes is related to hypopituitarism. The paper said the non-alcoholic fatty liver disease are caused in pituitary and hypothalamic dysfunction. The reason and pathogenesis is under investigation, so I cannot make it clear why it is related to non-alcoholic fatty liver disease and craniopharyngioma directly, but we can say that it is related at all. So we think the rupture of esophageal varices are related to the past medical history, and the symptoms are cause of rupture of esophageal varices below. We found the ascites. It is connected to shortness of breath. The breathing makes it the syncope. He also has back pain. It was related pain of rupture of esophageal varices. So all symptoms are connected to the final diagnosis, and the pathomedical history is very important not to miss the disease. So focus on the conclusion. We have to keep in mind today's 3 tips is below. Listen to your patients and their family. They will tell us the diagnosis, and it will be very helpful. So asking them in detail is very important. And the second one, the rank the multiple complaints in order of importance. Sometimes the patient said many things, back pain, and tachycardia, and chest pain, or blah, blah, blah. It makes us to be confused, and we will miss what is the most important. So please make the list of the chief complaints and rank the multiple complaints in order of importance. So we will approach the most important thing. And when you see the painting, please make it clear whether mental status or syncope, because the differential diagnosis are so different, and laboratory the order of laboratory data also different. For example, if we should think IU tips, we have to order the many laboratory data. But if we think syncope, we did lecture exam and we suspected breathing from the first time. So it can be not so expensive, and diagnose quickly and precisely. So here is my lecture, and thank you for listening. I hope you enjoy it. So did you understand?
Okay, thank you very much, Dr. Sayaka Aoyama, for great presentations. I think we can take the take-home message for your presentation that we have to listen to our patient, that the medical history is very important. And then we have to rank the important compliance and make a list, and which is the most appropriate with the patient condition. And then we have to differentiate which one that we have to go deeper to establish the diagnosis for the patient, right? I think we still have 5 minutes for discussions. I will ask the audience if there is any question for Dr. Aoyama. Please, you can ask directly in this session. Yeah, because we still have 4 minutes, 5 or 4 minutes left.
Yes, and if you have questions, please, I will do my best. And if you are shy, please contact me by Facebook.
Yeah. Okay.
Yes, I really appreciate the Indonesian people. When I was honestly, the 5 years ago, one Indonesian person helped me a lot, and I'm
Okay.
very thankful to Indonesian people. And I hope to help if I can do anything.
Oh
Indonesian
yeah,
people are very kind, and I'm happy to join today.
Okay, thank you very much, Dr. Aoyama. You are very welcome to come to Indonesia, maybe in the conference next year. Yeah, you can see
I
in
hope so,
person.
inshallah,
Yeah.
inshallah.
Okay, thank you very much. Okay, maybe if there is questions for Dr. Aoyama, you can write it down in the chat box, or maybe Dr. Aoyama let us if we want to ask question. It's also okay to contact her in the Facebook, right? Okay, we will search your Facebook later.
Yeah.
Okay, okay. Maybe we can move to the second speaker. Is it okay? Okay,
Yes,
so
please.
okay, our second speaker is Dr. Shun Yonezaki. He also from the Department of General Medicine, Mito Kyodo General Hospital, Japan. He is graduated from the University of Tsukuba in Japan. And currently, Dr. Yonezaki is a fourth-year resident. So Dr. Yonezaki is a colleague of the Dr. Aoyama, right? Okay, so Dr. Yonezaki will present elderly patient as well as the same, but the patient presented with altered mental status. Okay, so we invite Dr. Shun Yonezaki. The screen is yours, please, Dr. Yonezaki.
Okay, thank you very much for the introduction. So I'm going to share my slide. So can you see my voice and can you see my slide now?
Yes, yeah,
okay.
your voice is very clear, yeah.
Okay, so hello everyone, so nice to meet you. My name is Shun Yonezaki. I am a PGY4 resident doctor. And this is a slide, a picture I visited Indonesia. I also visited Indonesia twice before. And this time I visited Indonesia to teach Japanese for the Indonesian people in the south part of Jakarta. So I am the PGY4 legend doctor, and I am a colleague of the Dr. Aoyama, working in the same hospital. And I've been recently giving an online case conference for the medical students. And today's my case is 119-year-old, the 90 years old man with an altered mental status. So the chief complaint is our altered mental status. 93-year-old man with a chronic heart failure and atrial fibrillation. On the day of admission, 1 hour before, the patient fell into a sleep at 8 p.m. and 10 minutes before, the staff of the nursing home realized that he seemed sick and he was unconscious, and the blood pressure and oxygen saturation could not be detected, so the staff called the ambulance. According to the staff, he didn't hit his head, and the staff denied that he complained of fever, cough, dyspnea, chest pain before falling into a sleep. The past medical history is significant for the chronic heart failure, atrial fibrillation, hypertension, hyperlipidemia, and the dementia. The medication, he is on the bisoprolol, furosemide, spironolactone, valsartan, PPI, and zolpidem. A social history, he lived in the nursing home and he barely able to walk using a walker, and he is difficult to communicate because of the severe dementia, and he never smoked and he never drank alcohol, and there's no food and drug allergies. On the physical examination, the general appearance, he seemed very sick, and GCS is E1V3 M5. The blood pressure is 80 at 89 per 62. Heart rate is 85, irregularly irregular. Respiratory rate is 28. Body temperature is 37.2 Celsius. Saturation is 81% on the non-reservoir mask, 15 little. And on the lungs, there's a decrease in the blood sound bilaterally, but there's a no rail. The heart rate is irregularly irregular. There's no rebound tenderness, no abdominal pain, and there's no lower extremity edema. And the arms and legs move normally. So overall, the 93-year-old man with a chronic heart failure and atrial fibrillation presented to the ER because of the altered mental status, and he had hypoxia and hypertension. So what is your differential diagnosis? That he has altered mental status and hypoxia and hypertension. So this patient has a sleep problem. The first one is the altered mental status, and the second one is a hypoxia, and the third one is a hypertension. So he has a sleep problem. So for the first time I see this patient, I was like, how do you think the differential diagnosis for this patient? And I give one tip for the differential diagnosis. Think differential diagnosis in the order of A, B, C, D in ER, which is airway, breathing, circulation, and dysfunction of central nervous system. And in this patient, he has hypoxia and hypertension, so he has problem in the breathing and circulation. So let's think of the differential diagnosis of breathing and the circulation. Let's think of the differential diagnosis, hypoxia and hypertension. So the differential diagnosis for hypoxia, we can think of the pneumonia or heart failure or pneumothorax or myocardial infarction or pulmonary embolism or aortic dissection. On the other hand, for the differential diagnosis for the hypertension, we can think of the GI bleeding or sepsis or anaphylaxis or cardiac tamponade. That's my differential diagnosis for hypoxia and hypertension. So first, we think of the differential diagnosis. And my second question is, what exams to order to think of those differential diagnoses? Please think for a moment that maybe like what kind of exam you order when you see the patient. So in this patient, we ordered the laboratory data, ECG, X-ray, and ultrasonography, and the computed tomography. So let's see the laboratory data. On the coagulation test, the D-dimer is highly elevated, and on the arterial blood gas, the lactate is a little bit elevated. On ECG, the heart rate is 86 per minute, irregular, and the patient has atrial fibrillation burst. There's no STT change, which show the myocardial infarction. Let's see the X-ray. The CTR is 68% and the CP angle is sharp. And there's an infiltrate on the right upper lung X-ray. And we perform the ultrasonography on the EL. The visual EF is 50%, and there's no assynergy and no pericardial effusion. So we ruled out the possibility of the myocardial infarction or cardiac tamponade. And the patient has the moderate AL and severe TL, and there's a D shape, and the TLPG is 43, and IVC is 25, and there's no respiratory fluctuation, and there's several high echo particles moving to IVC, and there's no ascites. We also took the CT, and there's an infiltrate on the right upper lobe. We also took the brain CT, and there's no hemorrhage. And the contrast CT, there's no pulmonary embolism. And we also took the CT finding, other CT findings. There's a left femoral neck fracture. Here is in the X-ray, and here on the CT findings. So we ask the staff of the nursing home, the further inquiry of the staff. The first time he didn't talk about this finding to us, but when I asked again, he said 12 hours before admission, the patient fell down and struck his hip on the floor. And 3 hours before the admission, the patient fell down again, and he was not able to walk because of the pain. And this is the new fact. And let's see the ultrasonography. Numerous white floating dots moving toward the right atrium from the inferior vena cava. You see the several the floating dots. I share again. So the problem list for this patient, that he has an altered mental status, hypoxia, hypertension, infiltrate on lung X-ray, and right ventricular overload, and left femoral neck fracture. So overall, the 93-year-old man with a chronic heart failure and atrial fibrillation presented to the ER because of the altered mental status, and he fell down and hit his hip on the floor 12 and 3 hours before the presentation. And he has a severe hypoxia and hypertension, and the lung X-ray showed infiltrate, and CT showed the left femoral neck fracture, and UCG revealed the right ventricular volume overload. So my final question is, what is your final diagnosis? What is the diagnosis of this patient? My tip for the differential diagnosis, the list of all of the differential diagnosis, all of the possible diagnosis of the patient as much as possible, and rule out them one by one. So let's see. So the differential diagnosis for the hypoxia and hypertension, we think of those differential diagnoses: pneumonia, heart failure, pneumothorax, myocardial infarction, pulmonary embolism, aortic dissection, GI bleeding, sepsis, anaphylaxis. But there's no sign of pneumonia, no sign of heart failure. There's no pneumothorax. There's no sign of the myocardial infarction, and the contrast CT ruled out the pulmonary embolism, also aortic dissection, and the patient doesn't have GI bleeding, and there's no sepsis, any kind of the bacterial infection. There's no anaphylaxis and the cardiac tamponade. So what is the diagnosis for this patient? The important finding is the past history of the falling down on the same day he came to the hospital, and the sign of the femoral net fracture. So the altered mental status, hypoxia, hypertension, also the left femoral net fracture, infiltrate on the lung X-ray, right ventricular volume overload, and the hyperechoic particle in IVC is consistent with the diagnosis of the fat embolism syndrome. So this patient has the fat embolism syndrome. Let's see the clinical course during the hospitalization. The intravenous crystalline and oxygen administration were initiated. However, 5 hours after admission, saturation was gradually decreasing, and unfortunately, he expired. So in my session, I'm going to talk about the fat embolism syndrome. What is all about the fat embolism syndrome? The fat embolism syndrome is a rare condition defined by the presence of the fat globules in the respiratory circulation, and the classic triad are hypoxia, neurologic abnormality. In this patient are altered mental status and petechial rash. And fat embolism syndrome typically manifests after long bone and pelvic fracture, as the same as this patient, and there's no definite therapy. Epidemiology, the incidence of fat embolism syndrome has ranged from 1% to 30%, and 0.12% in patients with isolated orthopedic fracture. On the pathogenesis, there are two pathogenesis, and organ personality is thought to be mediated by two main processes. The first one is the mechanical theory. The fat from the disrupted bone marrow or adipose tissue enter torn venules following trauma. And the second one is a biochemical theory. Embolized fat degrades into toxic intermediately with a pro-inflammatory effect. The clinical presentation is very important. The fat embolism syndrome manifests 24 to 72 hours after the initial insult, and the symptoms are hypoxemia, neurologic abnormality, and petechial rash. Let's see. The respiratory abnormality, the hypoxia is the most common presenting feature, and X-ray and CT are mostly normal. And a minority of the X-ray reveal airspace disease like this patient. The neurologic abnormalities, this also happened in the 59% of all of the patients of the fat embolism syndrome, and typically manifest after respiratory abnormalities and focal deficit, confusion, lethargy, restlessness, and coma happened. And MRI sometimes shows star-like pattern of diffuse punctuate as this MRI. And most of the time, CT is a non-specific. The petechial rash also happened in 20 to 50% of the patient. The red-brown petechial rash, as these pictures, and this happened on the head and the neck and anterior thorax, axillary, and subconjunctiva. And the diagnosis is very difficult because there's no standard diagnostic criteria, and the diagnosis can be made when the classic triad of hypoxia, neurologic abnormality, and the petechial rash occurs in the appropriate clinical settings. So the most important point is the symptom and the past medical history, and also if the patient has the history of falling down before, and other diagnoses needed to be excluded, such as pneumonia, heart failure, ALDS, embolization syndrome, such as pulmonary embolism, or tumor embolism, or air embolism, or vasculitis disorders, such as SLE. The ultrasonographic finding of fat embolism syndrome. The fat emboli can be detected using a transesophageal echocardiography during orthopedic surgery, and the use of the ultrasound imaging is not well studied, but recent case reports have described that transthoracic echocardiography detect fat emboli, and this case emphasized the utility of the transthoracic echocardiography to diagnose the fat embolism syndrome. So we also published this on the article. You can see the white floating dots on the ivory sea moving to the right atrium. And this could be, the fat embolism. For the treatment, however, there are no definitive treatment. So the supportive care is a standard treatment. The prognosis, most patients fully recover spontaneously, but however, mortality rate range from the 5 to 50%. So looking back on this case, the patient has the hypoxia and neurologic abnormality. In this patient, there's no particular rash. And the episode of falling down and left femoral neck fracture before the presentation, and there were hypoechoic particle in ivory sea. And we rule out the possibility of other disease, which are the pneumonia, heart failure, pneumothorax, myocardial infarction, and pulmonary embolism, and aortic dissection. So in this patient, the patient has the hypoxia, hypertension, and altered mental status. And we think of any kind of the possibility of the differential diagnosis. But in this patient, the diagnosis is very difficult for us. So here is a take message on this case. Think the differential diagnosis in the order of A, B, C, D in EL, which are the airway, breathing, circulation, and dysfunction of CNS. So the chief complaint of the altered mental status, but in this patient, what is important is a breathing problem. So we focus on the problem with the breathing firstly. And my second tip is list up all of the differential diagnosis as much as possible and rule out of them. In particular, when we see the patient, the diagnosis is difficult, we need to think all of the potential diagnosis, all of the possibility firstly, and rule out one by one by asking the history and taking physical examination and checking the result of any kind of the data. And cite fat embolism syndrome, seeing the patient presenting with hypoxia and altered mental status. So this is my take-home message of this case. And thank you very much for listening to my case.
Yeah, thank you very much, Dr. Yonezaki. Your case is very interesting. I think it's very difficult to establish the diagnosis. It's a rare patient, I think. Yeah. So we still have 10 minutes for discussion session. So we ask to the audience if there is any question, you can raise your hand and directly give the questions, please. Okay, guess we're still waiting.
Vivo for
Oh, okay. Vivo, raise hand. Yeah, please. Please, Wibowo, you can ask your.
Vivo-san, please ask your question to Dr. Yonezaki.
Okay, please. Still, yeah. Still mute.
Hello.
Yeah, yeah, we can hear your voice now. Yeah, please.
I'm sorry I cannot show
Dr. Wibowo.
the video, Miss Andraini. I hope my voice is clear enough. So
Yeah.
Dr. Yonezaki can hear my questions.
Yes, clearly.
Okay, thank you, Dr. Yonezaki and this IMERI. I'm Sabta Wibowo from Jakarta, Indonesia. Interesting case that you have shared with us, Dr. Yonezaki. My question are two. The first one is if the diagnosis was a fat embolic syndrome, is there any consideration that the patient is elder or young people, or even in young people, or even in children perhaps? I thought the diagnosis when the patient entered the emergency was a heart failure with acute attack. So can you tell us what you can tell us about this patient and how long the patient with the fracture before, so the onset of symptoms, or even the attacks of this, it needs some time period, for example 3 or 5 days after fracture. The second question, Dr. Yonezaki, is the treatment for the fat embolic syndrome is only palliative or supportive treatment. Is there any consider for geriatric patient, especially in this patient that you have faced with? That's all my questions, and thank you for your discussion, and thank you for IMERI. Thank you, Dr. Yonezaki and Ms. Andriani. Thank you.
Thank you, Dr. Wibowo. Dr. Yonezaki, you can directly answer the question, please.
Okay, thank you very much for the great question. For the first question, I also first time this patient, I thought the patient has a heart failure. However, the patient doesn't have a heart failure, and because mostly the fat embolism syndrome occurred after the fracture, so the most of the patient are the, how can I say, the elderly people, not children. Maybe there's a case on the children, but most of the case are the elderly, as long as I know. And for the second question, like, is there any, come again, can I ask you a question again, the second question?
Yeah. Dr. Wibowo, could you please repeat your question? Yeah, I think it's regarding the
second question.
Therapy, is regarding the therapy. Dr. Wibowo, could you please repeat your questions? Son again, please.
Okay,
Please.
yeah, thank you,
Okay.
Miss Andrea, Andraini. The second question is how in elder people, in elder patient like this patient is 93 years old. So is there any geriatric problems, especially when in normal patient or even cardiac cases? We have some obstacles or even some challenges. So what is with the current condition with his heart, with your findings, and what is the main focus on this treatment, especially in a geriatric patient?
The treatment for the geriatric patient for the fat embolism.
Yes,
Yeah,
please.
actually, like as long as I search for some article, there's most of the most important treatment is the palliative treatment. So just like giving the oxidation or intravenous crystallite. But some reports said that maybe there's a merit for administering how can I say the steroid to support the cardiac function and the pneumonic pulmonary function, but there's no definitive evidence for administering steroid. So and I think like most important point of the fat embolism syndrome is avoid the fracture, because why this patient fall down? This patient is 93 years old and dementia, but he was barely able to walk before come to the hospital. And this patient has a zolpidem, which is the medication for the insomnia. And because of the doctor subscribe the patient the zolpidem, the patient like sometimes has syncope or fainting. So I think that's why in this patient, the falling down happened. So I think the most important point of the fat embolism syndrome is to avoid falling down.
Okay. Okay, noted, Dr. Yonezaki.
Okay, thank you for the question.
Thank you again, Dr. Yonezaki.
Okay, yeah, thank you, Dr. Wibowo. We still have one question from Dr. Sukma Purbowo. The question is, how about the antiplatelet agent administration? Is it recommended for this patient?
Antiplatelet agent for the fat embolism syndrome, it is not recommended.
Oh, okay. So it's not recommended. Okay. Okay, we still have 2 minutes for discussion. Is there any question, please?
Unfortunately, this patient expired.
Okay. Yeah. So your patient is not survived, you mean?
Yeah, not survived.
Oh, I'm sorry to hear that. Yeah.
Yeah. So we ask we ask for the family of this patient and to to share this case. I submit the article of this patient.
Yeah. Okay. Yeah, but you already try your best, right? Yeah.
Yes.
Yeah. Okay. So it's really an interesting case that you have shared to us. Yeah, because at the first time the patient come to ER, we do not think that it will goes to the fat embolism syndrome. Yeah, but when you do the systematically examination to this patient, and then you get that this fat embolism syndrome is very interesting that you already done. Okay, because of the time limitations, maybe if there are another question for Dr. Yonezaka, maybe Yonezaki, I'm sorry. Maybe you could send the question to the committee, and then we can directly give the question to the Dr. Yonezaki. Okay, maybe we are in the end of our sessions. Thank you very much, Dr. Yonezaki and Dr. Aoyama for your presentation and very good discussions, and both case is very interesting, rectal esophageal varices and the fat embolism syndrome, and you already teach us how to do the good diagnosis for this case, and then we can determine appropriate treatment for this case. Okay. If there is feedback for this event, please do not hesitate to let us know through this link. I will share the link here. Could you see this? Yeah, here. Okay, I will put it again also in chat. Sorry, in chat box. Okay. Okay, thank you everyone, and thank you for the speaker. So we can close the sessions. See you in the next online lecture series. And bye-bye. Yeah, please give applause and reaction for our distinguished great speaker. Thank you very much.
Very
Yeah.
much.
Yeah, see you again, and I hope we can see in Indonesia, Dr.
Yes,
Aoyama and
in the
Dr.
future.
Yonezaka. We really looking
Yeah.
forward your attendance in Indonesia.
Yes, thank you very
Thank
much.
you very much.
Thank you.
Okay,
Bye.
bye. See you again next session. Yeah.